Right. Hello, everyone. Welcome to the Virtual Rheumatology Collaborative Lecture Series. We have a great talk in store for us here today. My name is David Leverins, and I'm a rheumatologist at Duke University. I'll be one of your moderators today, along with Dr. Jean Lin, who is a fellow at Northwestern University. To make sure everything runs smoothly, I want to remind everyone of a few ground rules. All of you are muted except for the speakers. We do encourage all of you to ask questions throughout the talk. In order to ask a question, please press the Q&A button and write your question. Dr. Lin and I will go through the questions and present them to our speakers at the end of the talk. The chat feature is for general comments, and everything you write there can be seen by everyone. And if you're having an issue, please press the raise your hand button, and the host will come to your assistance. Okay, with that, I'm going to turn things over to Dr. Lin, who will be introducing our speakers.
Hi, David, thank you for the kind introduction. Right now, it's my absolute pleasure to introduce two phenomenal colleagues from Northwestern who will be leading the discussion today on COVID-19 and rheumatology, a critical review of the literature. Anisha Dua is an associate professor of medicine in the Division of Rheumatology, the director of the Northwestern Vasculitis Center, and the director of the Rheumatology Fellowship Program at Northwestern. She has served in leadership capacities both locally and nationally through the American College of Rheumatology, the Vasculitis Foundation, and the ACGME in areas of education as well as vasculitis. She is incredibly thankful about all the excitement and collaboration that has made this virtual program a reality. In addition to all her professional accomplishments, she's also an avid believer in wellness, which is so important in this pandemic, and does pottery for relaxation. Next, I want to introduce Michael Putnam. Mike, #EBRoom, is a clinical instructor at Northwestern University at Chicago, Illinois. He studies large vessel vasculitis on a T32 training grant and will continue his work on an RFF Scientist Development Grant next year at the Medical College of Wisconsin, where he will be an assistant professor of medicine and the medical director of the vasculitis program. When he's not reading the literature to change the world, he's playing with his children and becoming a grill master. I turn the presentation over to you guys.
Thanks, Jane.
All right, everyone, we're really looking forward to your participation. Thank you so much. We will go ahead and get started with the talk, and we're going to actually start this off with some polling questions. So, Mike, if you want to go ahead. These are objectives. You can read them. We don't really have any disclosures. All right, so we're going to start with some poll questions to try to just get a sense of where everyone's from, what's going on, and then a couple questions that might help us just in terms of informing our talk. So, Ngozi, if you want to go ahead and do those. If you guys don't mind filling them out, that would be much appreciated. All right, I feel like people probably know the answer to this one for themselves, so I think we'll close that poll and go to the next question. These first few questions are just really demographic questions, and we'll share the answers for the questions that have to do with our talk. All right, I think we can probably go to the next one. And sorry for having to do all these questions up front. This is just how the system works. We weren't able to integrate them into the talk, so we might reference back to it, but. All right. Hopefully I'm not moving too quickly, but let's go to the next poll question. So this is getting a little bit into informing our talk. So have you been asked to prescribe rheumatic disease therapies to non-rheumatic disease patients diagnosed with COVID-19? All right, I think that, is that fair enough time? Can we see the results of that? Okay, so 21% say yes, they have been asked. 73% say no, that they have not been asked to prescribe our drugs to non-rheumatic disease patients with COVID-19, and 7% are not applicable. And we can go on to the next question. Would you recommend starting hydroxychloroquine to treat a non-severe case of, I think cut off, but clearly COVID-19, that's what the talk's about. So would you recommend starting hydroxychloroquine?
Oh, no.
Oh, I guess it's not clear. It's not lupus, it's not rheumatoid arthritis. Would you recommend starting hydroxychloroquine to treat a non-severe case of COVID-19?
Case of COVID-19 in particular.
Yes. All right, Ngozi, you want to show us the results? Okay, so 18% say yes, they would recommend it. 80% say no, they would not recommend it. And 3% say not applicable. All right, thank you. We'll go to the next question. Have your patients reported difficulties obtaining hydroxychloroquine during the past 28 days? So these are your rheumatic disease patients that are on hydroxychloroquine. Okay, I think that's probably good. Can we see what the results are? 74% say yes, they have reported difficulties obtaining hydroxychloroquine during the past 28 days. That's a lot. 21% say no, and 5% say not applicable. So there's definitely a lot of us that have dealt with our patients having trouble getting access to this drug. Okay, and there's not too many questions left. I think there's one or two, so we'll go to the next one. Would you request hydroxychloroquine if you personally contracted COVID-19? Okay, I think we can probably see what the results are. So 30% say yes, they would. 68% say no, they wouldn't. And 2% said it's not applicable. I don't know how it's not applicable, but okay. That's fair. So do we have any more poll questions, or are we ready to get into?
Yeah. One on IL-6, then we're done.
Okay. Oh yeah, one last question. So would you recommend IL-6 inhibition to treat a hospitalized patient with COVID-19? All right, let's see what the results show. So 59% say yes, they would recommend it. 38% say no, so that's a pretty reasonably even split. And 4% say not applicable. Okay, thank you guys very much for participating. It's really interesting just to get a sense of where people are at, what they're facing, and what they would do clinically and for themselves. So we're gonna go a little bit into the talk now. And I'll start off. I took the easy part and I gave Mike the hard part because I'm the program director and he's my fellow. So currently, there is no evidence from randomized clinical trials that any potential therapy improves outcomes in patients with either suspected or confirmed COVID-19, or data to support prophylactic therapy. More than 300 active clinical treatment trials are underway, and there's a really rapid race to try to gather information and to try to manage this pandemic. But as you can see here, more data is not always equal to good data. And it's important for us to try to understand what the rapidly expanding body of literature surrounding COVID and the use of anti-rheumatic drugs means for the pandemic and also for our patients. So during this talk, we'll briefly address some of the theoretical rationale behind the use of anti-rheumatic drugs in the treatment of COVID-19 patients, and then focus really on reviewing and making sense of some of the data that's been reported. Next slide. So we're gonna start off with just a little background about the virus. SARS-CoV-2 is a single-stranded RNA envelope virus. It targets cells through the viral structural spike or S protein that binds to the ACE2 receptor. The virus uses the host cell receptor and the endosomes to enter the cells via this S protein. And once the virus has entered the cells, polyproteins are synthesized that encode for viral replication and transcription. So this enables the virus to synthesize RNA with eventual release of viral particles. So this schematic here shows multiple potential drug targets that try and block this process of viral entry, replication, and of course, release. For the purposes of this talk, we're gonna focus primarily on chloroquine, hydroxychloroquine, and IL-6 blockade. All right, go ahead to the next talk. So we know there's been a ton of excitement around anti-malarials, and without getting too political, we know there are a lot of fans out there. So why, in theory, might these drugs work in COVID-19? So one first mechanism is by decreasing viral entry. So by interfering with the glycosylation of host receptors, such as ACE2, which I just mentioned, which the virus uses to get inside the cell. So that's one possible mechanism. A second mechanism is by disrupting endosome function through altering the pH. So the virus can use endocytosis to enter the cell, and at an acidic pH, the viral and the endosomal membranes fuse, leading to release of the viral genome into the cytosol and production of enzymes that are necessary for replication. By increasing the pH, Plaquenil or hydroxychloroquine or chloroquine can potentially disrupt this process. A third potential mechanism is through inhibiting phosphorylation or activation of MAP kinase. Activation of cells via MAP kinase signaling is frequently required by viruses to achieve the replication cycle. And then lastly, chloroquine can interfere with the post-translational modification of viral proteins. These modifications, which involve proteases and glycosyl transferases, occur within the endoplasmic reticulum or Golgi apparatus, and they may require a low pH. So those are some potential mechanisms that theoretically give support to the use of these antimalarials in terms of treating a virus. Go to the next slide. Okay, so as rheumatologists, we are often accused of loving corticosteroids and jumping to them as a potential treatment for any of our diseases. We know that there's significant side effects, including infection, but we also know that steroids decrease inflammation and that there's controversial evidence regarding the efficacy of steroids in ARDS and septic shock, which affects a proportion of our patients who are in the ICU currently with COVID-19. Because we're notoriously in charge of this drug, I think there might be a fly-in. Can you press the next advance? Yep. So because we are, sorry, one second. Because we're notoriously in charge of this drug, it's our responsibility to look at its use closely to determine what role it may play in exacerbating or tempering morbidity and mortality in COVID patients. If we look back at observational studies in patients with SARS and MERS, steroids did not improve survival and were actually associated with delayed viral clearance from the respiratory and blood tracts. A meta-analysis of more than 6,000 patients with influenza pneumonia found that steroids were associated with an increased risk of mortality and a twofold higher risk of secondary infections. And while we cannot and should not extrapolate from other disease states whether or not to use steroids in COVID-19, it's important to historically frame how steroids have performed in severe viral diseases. It's yet unclear whether there's a role for the initiation of steroids in the management of patients with severe COVID. And then next slide, this is one last theory slide before we delve into the data. So once the virus infects a cell, we know that there's rapid replication and activation of our immune system. As rheumatologists, we're well-versed in some of the downsides to intense immune activation, and we've seen the damage that can happen when patients are affected by cytokine storm in diseases that we manage, such as MAS. This virus has been demonstrated to result in a large amount of cytokine activation, which may be driving severe lung injury in some of the patients affected by COVID-19. Some preliminary studies of COVID-19 patients have shown elevation of cytokines, especially IL-6, in critically ill or intubated patients with high oxygen requirements. So the role that cytokines play in driving and perpetuating damage to the lung tissue has led to investigation of the blockade of these cytokines, such as IL-6, IL-1, TNF-alpha, and others. And I'll pass it over to Mike to get into the data. So these are the theories, but now we're going to talk about what we've found so far.
All right, thanks a lot. So appreciate everyone for coming and listening. I hope this is helpful. My goal is to just talk about the data that we have and try and put some of our various treatments into context. So I'll start with where I first became aware that we would be deeply involved in this, which is Twitter and Elon Musk. So he tweeted out on March 16th, "Maybe worth considering chloroquine for C19." I didn't tweet this out, but this is what I said. I said, what? Because I really didn't see this one coming. So let me give the background for this, for why this was at least initially interesting. This is a preclinical data to start. Now, this is a nice study of remdesivir, a number of things, but it included chloroquine. And what they did is they looked at a simian model, and they asked the question, if we give chloroquine to cells that and expose them to SARS-CoV-2, what happens? And the answer is that it looks like there's some inhibition of viral replication. And so that's on the left axis here in red. And then on the right, there's cytotoxicity. So is this killing cells? And it looks like it didn't. And so the conclusion from this is that, it looks like chloroquine may inhibit the viral replication, but it also, and it may do so at a concentration that does not kill cells, in this case, simian cells. There's a couple issues with this study, in particular, it's a non-human primate and then it's in vitro. This is some pretty immuno pictures to show the same. And then more to the point for us in hydroxychloroquine, there's another paper that came out shortly thereafter. And, they said, and I love when papers have choice quotes like this. They said, "It is easy to conjure up the idea that hydroxychloroquine may be a potent candidate for treatment infection by SARS-CoV-2. Let me tell you, there's been a lot of conjuring up since then. So I think that was apropos. They had a similar model. They looked at Vero E6, which is a simian model. And they again compared the percent or the effective concentration for hydroxychloroquine and chloroquine. And what they saw is that, hydroxychloroquine also seems to inhibit viral replication at a similar profile, but hydroxychloroquine is probably better tolerated, which is one reason that we got thrown into the mix. Same drawbacks. This is a non-human primate model, and this is in vitro data. This is not in a living system. But I think that at least the basic science rationale for pursuing these drugs was pretty strong. Now I'm going to try. There's a lot of studies I'm going to talk about, so I'm going to try and pepper in a couple little brief asides of just medical interesting things. And this is one of my favorites that I want to share with y'all. This is how often highly promising stuff in basic science findings translate into effective treatments. This is a paper by the Ioannidis group from 2003 in the American Journal of Medicine. And what they did is they looked at the 6 most highly cited basic science publications. This is Science, Nature, Cell. These are like the best of the best. And they looked at 4 years or 5 years of publications, and they looked at every article that was published. And they said, did any of these articles identify a highly promising therapy? And then they looked for 20 years afterwards to see what happened with these highly promising therapies. They identified 163 potential and then 101 articles that were highly promising. And this is what happened. Out of those 101 most highly promising things in the best journals that we have, only 27 ever actually had an RCT performed, and only 19 had any positive results. And as far as actually being used in clinical practice, only 5 out of 101 were actually translated into clinical practice. It's worth noting that this probably overestimates how well basic science translates into clinical medicine, because again, these were the best journals that there are. This is a dated study. Things have happened since then, so maybe we're better now. But I always think it's worth being a little cautious when you see a simian model that reports 100% effectiveness. And on that happy jumping off point, I'd like to start to talk about some clinical data. This is my summary of preclinical data. We should investigate hydroxychloroquine and COVID-19. I think it's pretty straightforward. So to kick this off, I would like to start with sorry, hold on. I'm having some technical problems here, guys. I don't know if you guys can still see me. It looks like my camera's malfunctioning or something. Just give me a second to get it all back running again. All right, we're back. Okay, so this is a great quote by the good Dr. Didier Raoult, and he said, if clinical data confirm the biological results, the novel coronavirus-associated disease will become one of the simplest and cheapest to treat and prevent among infectious respiratory diseases. Now, let me tell you, that is a bold proclamation, especially given what we've seen since then. So let's talk about the actual data. So this is the first paper that kind of set all this off. It was entitled Hydroxychloroquine and Azithromycin as a treatment of COVID-19, results of an open label, non-randomized clinical trial. So, at face value, I think we should question whether or not this is actually a clinical trial. It was a clinical trial in the sense that they tried hydroxychloroquine, but not in the sense that there was a real control group. What they did is they gave hydroxychloroquine, TID, for 10 days to a treatment group. And then patients who refused it were considered the controls. Patients from other centers were also lumped into that group. And then the primary outcome was virological clearance at 6 days. Now, what did they find? Well, of their 26 patients who were put into the control group, or were put into the treatment group, 6 were lost to follow-up. Of the 20 that remained, 70% cleared the virus at day 6, and that's compared to 12.5% in their control group. So that's a better number. It's a bigger number than 12.5%. And then they also gave azithromycin to 6 people, and all of them got better. So again, that's a strong finding. There are so many limitations to this paper, though. I mean, the endpoint is mediocre. I mean, the goal is not to clear virus. The goal is to prolong people's life. The goal is to prevent them going to the intensive care unit. The control group was poorly conceived. I mean, if you take patients who, and you all know this, so if you have a patient who refuses methotrexate compared to a patient who says, sure, I'll take methotrexate for my rheumatoid arthritis, we all intrinsically know that that patient who said yes to methotrexate tends to do better. And there's a variety of reasons for that aren't just related to methotrexate. The testing of these groups was different. And then most concerningly, I just cannot believe that this happened. They lost 23% of the treatment arm to follow-up, and the reasons were pretty concerning. So 3 patients went to the ICU, 1 died, 1 had adverse events, and 1 just kind of left. John Oliver had a good skit about this, where he said that it's easy to show 100% success if you ignore all of your failures. So in conclusion, I mean, this is a study that kind of ticked things off, but it is a very flawed study, and certainly not something I think we should be making public policy based upon. Now, they followed this up with a series of 80 patients who had COVID-19. Same group, same centers. They actually had 6 patients that overlapped, which is another methodological question, but we'll put that aside for now. And in this study, they did this national early warning news score where they calculated how sick the patient was, which is helpful because it did get to one of my main critiques of this type of research. The primary endpoint was initially discharge post-negative PCR, but then they kind of amended this given how things were going. Ultimately, they found 74 new patients. 41% only had upper respiratory infectious symptoms. So that's kind of what I have right now, which is, I have a runny nose and I feel a little under the weather. I don't know if those people should be hospitalized. 92% had a low news score, and then 4% of these patients were asymptomatic carriers. And I can't emphasize enough how strange it is to me that we're hospitalizing patients who are asymptomatic carriers. The problem with that being that we're taking people who have COVID-19 and are probably shedding virus, and we're pulling them into the building where the sick people live. That's the ethical side of it, but the methodological side of it is that it's not terribly surprising that these people did well if they were asymptomatic carriers. So as far as results, 81% had a favorable outcome, only 15% required oxygen, and patients all cleared the virus, or a mean length of stay of 4.6 days. So it looked like this cohort of people did well, but there's no comparator here. It was a very healthy cohort and possibly asymptomatic. They then followed this up by a series of 1,000 people. I can't tell you the title because it was just posted to their website. It's not really available. And in this one, all I can say for now is that the news score for these 1,000 people was very low. This was again a very healthy cohort. I think one of my mentors at Northwestern put this very well. He said, I think you should summarize the findings of this, and I put his quote at the bottom. It said, "We gave hydroxychloroquine and azithromycin to over 1,000 COVID-19 patients. Full stop." I mean, that's really what happened here, right? These patients probably will do well because they were probably healthy. And these are, profoundly problematic methodologic studies. All right. So with that, I'd like to transition out of that branch of the research and make a point, which is that ideas can also go viral. This is a graph that I put together a couple weeks back with help from Jean Liu, who's a room cat. We looked at internet search interest and we graphed it over time. And March 17th here, you can see the publication date of that initial paper. And all of a sudden, people care about hydroxychloroquine. And then March 19th and change, we had a presidential press conference that highlighted it as a potentially highly effective therapy. And you can see what happened, which is that interest in hydroxychloroquine spiked and concern about a hydroxychloroquine shortage went up dramatically. I'm glad we did this poll because we can now sort of share with all of you what that looks like in practice. And what that looks like is 74% of us have had patients who have had trouble getting hydroxychloroquine, which is problematic to say the least. So anyways, I'd like to get back to some data because this is not all there is. There have been a lot more studies since then that have been published. So this is a preliminary study of hydroxychloroquine that was published, or that comes from China. I can't tell if this was published or if this is a preprint, and I can't tell if it was peer reviewed, but it was a randomized controlled trial that looks to be open label. They gave 400 milligrams of hydroxychloroquine for 5 days versus usual care. And the endpoint was, again, this virological clearance. Can't emphasize enough that this is not the endpoint we're looking for. This is a disease that really, really tragically kills people, and that should be our outcome measure. To get into the results of this study, 15 patients were randomized into each group. So that's 15 in the treatment group, 15 in the usual care group. Of those, 13 or 86.7% in the treatment group and 93.3% in the control group cleared the virus. So that was not significantly different, and that certainly does not corroborate the case for hydroxychloroquine and COVID-19. That being said, this is just another flawed study. I mean, it was small, it was underpowered, and it used the same questionable endpoint. So, the solution to questionable data is not to emphasize more questionable data, but it's an important data point to discuss. Now, thankfully, more work was done, and we have a lot more to talk about here. So the next study I want to talk about was entitled Efficacy of Hydroxychloroquine in Patients with COVID-19, another randomized controlled trial. So this one had a similar structure where they gave hydroxychloroquine 400 for 5 days. Patients were again randomized to treatment or usual care. And in this one, the endpoint was clinical recovery. Now, that's kind of a moving target, right? Like, I don't know exactly how to define clinical recovery in a syndrome like this. I think we're all accustomed to saying that coughs can last for 4 weeks, but often patients will be better. So, this is an interesting endpoint, to say the least. Cough, fever, and radiographic changes were all included in how they defined that. They ultimately got 62 patients to be included in their study. They were randomized evenly, 31 in each group. And what they saw was that the fever and cough and this clinical improvement did happen sooner in the hydroxychloroquine arm by about 1 day, give or take. So that's certainly something. They also saw that pneumonia improved on CT scanning, which, it's nice to see that they're scanning people and getting this information. It's kind of a more objective measure, I suppose, than the clinical endpoint. It improved in 81% in the hydroxychloroquine group versus 55% in the usual care group. And to me, that's somewhat encouraging. Now, as with these other ones, there are a couple of really important limitations to this study. The first is that this is an unvalidated clinical endpoint. I've never seen fever, cough, and radiographic changes as a standard means of measuring response to a therapy. More importantly, though, this trial was initially designed to address something entirely different. The endpoint had been virological clearance. So when you hear this fever, cough, radiology endpoint and think to yourself, kind of sounds like they mashed that together. We actually can say definitively that they kind of mashed that together after they'd seen the data, because their initial plan was not to use that. You don't know the degree to which this was done before they did the analysis or after they did the analysis, but pre-specified endpoints are very, very important in clinical trials, because if you change your endpoint after you've seen the data, the entire idea of testing a hypothesis kind of breaks down. You're no longer performing a trial with a single outcome. You're performing more of an observational study. Now, they also did some inappropriate statistical methods. They used some t-testing when we don't think their numbers were actually normally distributed. And it's really unclear to me if this was actually blinded. The way they described it, they said that this was a trial of treatment versus usual care. And then they said that the patients didn't know whether or not they got hydroxychloroquine. but they didn't actually describe the process by which a placebo was used or kept blinded. And so I am not entirely sure if this is actually a blinded randomized control trial, which is a big issue because if you are giving someone hydroxychloroquine in an open label fashion, that introduces all kinds of bias. So the conclusion for this study was that the potential of hydroxychloroquine has been partially confirmed, which I agree with. Large-scale clinical basic science research is still needed. I really agree with that. I think that this is a data point in favor, but it is certainly not a terribly strong one. Now, if you'll notice, this trial was published in this medRxiv thing, and I imagine not all of you had heard of medRxiv before this began. I count myself in that number. So let me tell you a little bit about what medRxiv is. Now, this is a very useful thing that these folks have put together. I mean, it's put together by a group that you can trust. It's the BMJ and Yale. And the goal is to create a server or a repository of data before it's published. Publication process takes a long time, as I'm sure many of us are aware. And sometimes you need to get data out quickly. Sometimes you'd like to have data available for ongoing experiments and things like that. And so there's a medRxiv, there's a bioRxiv, and there's a China archive. And the idea is that they put information, publication or manuscripts out there before they are actually published. There's a couple problems with this. The main one is that they don't undergo a rigorous process of peer review. And the second one is that I use the journal that publishes information as sort of a loose heuristic for quality. If something gets published in the New England Journal or JAMA, it tends to be a good paper or a paper that was done well, and smart people have already reviewed it. When you don't have that check on the system, it's harder to know at face value how well something was done unless you really dig into it. And if it hasn't been peer reviewed, it makes it a little more challenging. Now, medRxiv has been in the news a lot because a lot of the information that we have thus far is there and not in the published literature. So I think the remainder of my talk is just medRxiv. So let's get into it. Well, let's see. All right, so the next study I want to talk about is a really interesting one. So this is another randomized controlled trial, and it's a larger one. This is a multi-center open label trial. So here they specified that they did let people know which group they were going to be assigned in. Patients were randomized to hydroxychloroquine at a high dose this time. They got 1,200 milligrams times 3 and then 800 milligrams daily. But this is an important point because one concern about the hydroxychloroquine studies is that we're giving it at rheumatoid arthritis or lupus doses for the most part. And folks who know what they're talking about seem to think that more hydroxychloroquine may be more effective. So it was good to see that this one used a large dose. Patients were randomized to this treatment or standard of care in an unblinded fashion. And the endpoint was negative conversion of SARS-CoV-2 within 28 days. So this is not the mortality endpoint that I'm looking for, but it is a larger, somewhat better designed study. 150 patients were ultimately included. 75 were split into each group. And here are the results, which is that there was really no difference in this viral conversion endpoint. 85% versus 81% had converted at 28 days. Now you may say, well, but 28 days is a long time. Of course, everyone converted by then. But this is a Kaplan-Meier curve that I'm showing here that shows that, at day 4, day 7, day 10, day 14, day 21, there really was no difference in whether or not people converted from virus to no virus. There were no subgroups that experienced significant benefit. And the CRP and lymphopenia did resolve more quickly. So here's that data, which is a laudable goal. I mean, it's good to reduce inflammation, but it is not the goal that we need. I think we have all treated patients with tocilizumab and watched their ESR and CRP disappear completely, and then have the patient come back and tell you that they feel way worse. So I think that this is an important thing to note, that hydroxychloroquine is anti-inflammatory, but it's also something that we already knew, and adding it here I think is helpful, but not something that would make me want to prescribe it necessarily. Now, in the study, there were more adverse events. The hydroxychloroquine group had 30% versus 9% in the treatment group. So that's actually an early sign of caution, but this trial wasn't powered to really assess adverse events. None of the adverse events were serious. And as a doctor who has spent the last couple of years telling my patients that hydroxychloroquine is safe and well tolerated, I don't want to jump on the run away from hydroxychloroquine bandwagon just yet. There are a couple of limitations that are worth noting. The first one being that there's a big delay in treatment initiation of 16 days. So it may be that we just weren't giving hydroxychloroquine early enough. And I don't love the outcome measure. So the authors conclude based on this study, though, that the results of our trial did not show additional virologic response by adding hydroxychloroquine to the current standard of care. I think that's a measured and well-supported conclusion by the data. Now, There's another study that was large and relatively well designed with a couple caveats that was actually recently halted that a lot of people have been talking about. So let me tell you about that one. This was entitled Chloroquine Diphosphate at 2 different dosages as adjuvant therapy of hospitalized patients. This is a COVID-19 study. In this study, it was large, which I really like. The sample size was 440 patients with suspected COVID-19. And that is a big enough study to actually use a real outcome measure. The endpoint was response versus historical controls. Now, this is really a problematic way to do a study. So they used as their historical controls patients in Wuhan who were probably very sick, and they pointed that was a 20% mortality. As such, they decided not to use a control group within their own cohort. I mean, there's a lot of interesting historical controls lately. I think the idea is that it's hard to do a controlled trial. In their case, they were concerned from an ethical perspective because in Brazil, chloroquine was essentially the standard of care. I think that I can see why they tried to do this. But when you think about it, it's a different country, it's a different continent, it's a different group of people, it's a different hospital, could be a different level of acuity, could be a different treatment paradigm. There's so many things that make this not really a control group. So I think calling this a historical comparator or something like that would have been more accurate. So what did they find? Well, they were planning to randomize 440 patients, as I said, but they only got to 81. After 41 had been allocated into the high-dose chloroquine group, and 40 had been allocated into the low-dose chloroquine group, again, no control group, they found that there was a 13.5% mortality, which is pretty high, but there was numerically higher in the high-dose chloroquine group. And so the Data and Safety Monitoring Board, which is sort of a group that looks after trials to make sure nothing scary is occurring, decided to halt the trial based on this trend towards more mortality in the high-dose chloroquine group. This is the data itself at 6 days. The 13-day data is a little bit scarier, but essentially it looks like the people who had high dose of chloroquine were more likely to go on to have bad things happen to them. At least at 6 days, this was not statistically significant, but I think that this is an important cautionary tale, and that more treatment and higher doses of a drug may be associated with more bad outcomes. So major limitations, like I said, are that the interim analysis due to premature stoppage is not entirely clear to me why they had to do that at that point. And then the comparison to historical controls makes this not the trial to assess whether or not these drugs actually work. And then finally, only 62% of 62 patients had confirmed COVID-19. We'll see this later in another study, but not all the patients for sure had COVID-19. They used suspected COVID-19 as their enrollment, which opens the door to treating people with the flu and things like that. Now, this actually takes me to the next study, which did a similar thing. So this is just landed last week, and it's kind of a regrettable thing. So this study is entitled Empirical Treatment of Hydroxychloroquine and Azithromycin for Suspected Cases of COVID-19, followed up by telemedicine. So to get in this study, you had to have flu symptoms and no immediate need for hospitalization. The control were patients who refused treatment. I already talked about how that is a very problematic group from which to derive a control group. The endpoint was not entirely clear. Now, they showed that there was a much lower need for hospitalization in the group that took these drugs as opposed to the group that refused them. But it's not clear that all these patients even had COVID-19. The control group was very poorly constructed. And the endpoint of hospitalization is very much dependent on what physicians decide to do. So if you're a doctor who thinks hydroxychloroquine works, you may be less likely to hospitalize them. So this was actually not even on the medRxiv. I found it on someone's blog, and that's how it made its way to Twitter. So the last study that I really want to talk about is this one here. This is a retrospective cohort that came out yesterday, so we are very up to date here, using VA data. It was on COVID-19 positive VA inpatients. They looked at patients who either got hydroxychloroquine and azithromycin, or got nothing. And the endpoint was death or the need for mechanical ventilation. That's great. Not an RCT, but it is a very well done cohort study. They used propensity score matching and some fancy stats, as I like to call them. And what they found is that the people who got hydroxychloroquine did much, much, much worse. So the rate of death was 28% versus 11% in the group that did not get hydroxychloroquine. Now, this is a problem because maybe the people got hydroxychloroquine because they were sicker. And so you always worry if there's some sort of indication bias where people are getting this medicine because they are worse. So they did some propensity score matching and some fancy stats to try and tell if that was the case. And even after doing that, it looked like the rate of death was higher in the hydroxychloroquine group. I mean, at the end of the day, this doesn't totally pass the sniff test for me. I suspect a lot of this is being driven by unmeasured confounding. But for me, what this says is that if there were a big benefit to hydroxychloroquine, we probably should have seen it in this study. It's like the Social Network movie where Zuckerberg says, you know, if you were the inventor of Facebook, you would have invented Facebook. I mean, I think that if hydroxychloroquine was going to cure COVID, it would have cured COVID. So just sad, because I think we all do really hope that there's something that's going to help us here. Now, briefly, I want to talk about our patients. There's some interest in whether or not taking hydroxychloroquine makes our patients somehow immune. And thankfully, the Global Rheumatology Alliance has already gotten some preliminary data that tells us that the answer is just no. Patients with our diseases still get COVID-19, and patients on hydroxychloroquine with our diseases still get COVID-19. So at least in our patients, we cannot tell them that they're worry-free. This is actually the COVID-19 website. I highly recommend anyone who's interested to sign up, enroll, chip into this initiative. It's a really great thing that people are doing to try to help out our patients. Now, thankfully, there are more trials underway in COVID-19, and this is hydroxychloroquine alone, but this is a lot of trials, and this is a problem. You'd think that many trials is good, but you know, as Anisha said earlier, more data can be confusing. In this case, more data raises the chances that we don't find anything, because these trials many of them are going to be underpowered and fighting over the same group of patients. And it also raises the chance that we'll find something erroneous, because small trials are more likely, due to the winds of chance and fate, to find some erroneous result. So this goes back to what I've been saying on the social medias quite a lot, which is that we just need 2 to 3 good randomized controlled trials. Thankfully, some of those exist, so hopefully we'll get the data soon. Now, there's a number of unanswered questions that remain, I think, which is, what about a higher dose of hydroxychloroquine? I think that that's an important one. What about starting earlier? Maybe earlier intervention is important. I think that's an important one to address. How safe it is in combination with azithromycin, I think we're all worried about torsades. And then does it work at all, which I think is a real question we need to answer. But I'd like to transition and talk about IL-6 inhibition, because this is the other kind of hot topic that a lot of us are being asked to prescribe. This is the preclinical data for IL-6 inhibition. There's not that much. But Anisha did a nice job of talking about the background for why this might be a good idea, essentially calming down cytokine storm. So let me tell you about a couple pieces of evidence that we do have. Now, the first is this one. This is a case series of patients with severe or critical disease by the Chinese criteria. They got tocilizumab once. They also got a whole bunch of other therapies. So it's hard to say which of those is really driving their outcome. 81% of the patients were severe, 19% were critical, and ultimately 91% were discharged from the hospital. So this is good outcomes, mostly, in a very sick cohort of people. And then, as you'd expect, CRP and lymphocyte abnormalities improved. This is a case series, and there's no control group. It is open label. So a lot of limitations to this kind of data. We've also tested cetuximab, which I had never used before, in patients with COVID-19 who are requiring ventilatory support. Now, all of them were on non-invasive, which I think is helpful, because that's the group where you kind of think about intervening and hoping to sort of bend the course. They got cetuximab once in addition to standard of care. And the results are, this, 33% improved, 43% stabilized, and 24% worse. That's really all we can say. We gave cetuximab to a couple people. They seem to have a decent outcome, but it's hard to put context into that without a control group. And then last but not least, this is a retrospective cohort study, again, of severe COVID-19 patients receiving tocilizumab. They looked at 69 cases. 11 were non-severe. I mean, that's not really a comparator, though, right? We're looking for a group that didn't get tocilizumab, not a group that was healthier and may or may not have gotten tocilizumab. In this study, 54% improved to discharge, 46% remained hospitalized, and 4% went to the ICU. There was no mortality. So again, I mean, this is data that tocilizumab was given, and patients had what could have been perceived as a favorable outcome. But without a control group, it's just hard to say. Trials on tocilizumab are also underway. There are a lot of them, but thankfully they're benefiting from the coordination of a couple large companies that are funding them and sort of making sure that we're not doing 20 different small studies. So I think that we'll have a good answer to the role of IL-6 inhibition in the near future. And I think anecdotally, a lot of us have had a good experience in using it. And so I'm hopeful that IL-6 inhibition will be a useful therapy, at least in patients who are relatively sick with COVID-19. So I'd like to now transition into what I call the data-free zone, which is a place where anything is possible and everything is awesome. A couple last therapies to round things out, and then we'll open the floor to questions. So the first is the baricitinib question. I get a lot of people reaching out on Twitter asking me if I'm using baricitinib if we should use baricitinib. As far as I can tell, this is where that comes from. There was a Lancet editorial written where they used some artificial intelligence program, which they named Benevolent, and it has structured medical information. They said, this is how COVID-19 replicates, what kind of medications could be used. And they came up with a number of different possibilities, but they thought that baricitinib would be the most helpful because it inhibits a couple of pathways that are important for COVID-19. So I call this level of evidence W, as in what about this? Because this is not even preclinical. This is not even basic science data. This is just essentially an AI that we don't know, kind of just combing through things. There's an editorial last week about TNF therapy in COVID-19. This is, I think, on a similar vein as the IL-6 therapy. We're trying to calm down the aberrant immune activation. Reasonable thought, but it has not been done. There's no data for this. And then there's a nice letter, again in Lancet, by Pooja Mehta in her group. And they talked about the cytokine storm side of this and mentioned a couple of other therapies, most notably IL-1 inhibition. Anecdotally, I've heard of people using IL-1 inhibition successfully in patients who are quite ill, trying to stave off the cytokine storm side of this. But there's as yet no clinical data that I've seen to justify that use. So these are options and things that people are considering, but I think really stressing that this is something people are considering and not something people are using first line is important here. Now, briefly, let's go to level of evidence, anything is possible, which is the story of NSAIDs. I tried to figure out where exactly this came from. As far as I can tell, there was a World Health Organization person who mentioned that NSAIDs could be associated with badness and respiratory diseases. That got picked up by the media. There may have been a doctor in France who had some patients who got ibuprofen and did poorly. Regardless, I think that this is mostly not something we need to put a ton of stock into. The FDA has come out and said that, and I quote, the FDA is not aware of scientific evidence connecting the use of NSAIDs like ibuprofen with worsening COVID-19 symptoms. I think that's an important data point. The World Health Organization came out and said they do not recommend against the use of ibuprofen. And the BMJ wrote a nice editorial, and they concluded by saying, so far we have no evidence relating specifically to people with COVID-19. So, 2 points to this. The first is that the BMJ editorial did talk about some data from randomized controlled trials in other diseases where there was some signal that NSAIDs could be troublesome, certainly for cardiac issues, maybe for respiratory as well. But the other is that, for our patients, what's the alternative? So if we take someone off their NSAIDs because we're worried about COVID-19 and they flare and we have to treat them with steroids, is that a net win or a net loss? And I'd be inclined to say that it's a net loss, but there's no evidence in any direction. So. Last but not least, I'd like to end on an optimistic note, leaving the world of rainbows and unicorns. So this is the data that I think we've all been tracking of cases by country. And thankfully, many of us have turned the corner off of the exponential growth phase. So really, really hoping that at least the things that we're doing start to continue to bend this curve. And the curve that does not seem to have bent yet is the growth of this literature. I'm very glad that I'm giving this publication or this talk right now, because it looks like about a week from now we'd have 2,000 more articles on COVID-19. This is a graph on the left that I put together of total COVID articles per week, and you can see an exponential growth in the PubMed literature. MedArchive and bioRxiv are both growing quickly. And cumulative articles, the PubMed is just skyrocketing. So I'm grateful to have given this talk. Thank you for having me, and I'm glad I didn't have to do it any later than today. So with that, I just want to open the floor to questions and just say thanks to everyone for tuning in. I think this is a great series, and I appreciate being a part of it.
Thank you, Mike. I know and thank you all for listening. I know there was a lot of data, and I gave Mike the difficult portion of this talk. But as you guys know, there's we're constantly getting more and more information. And it's not to say that that's not helpful. It's just trying to make sense of it can be obviously very difficult. And has downstream effects like limiting access for important drugs for our patients. So I think we'll have, if Dave and Jean want to unmute themselves and sort of log in and direct any questions, I will, as usual, direct the difficult ones to Mike and answer the soft ones.
Excited about this.
Perfect. Yeah. Thank you so much, both of you, for a wonderful talk. This was really interesting. I know we've all been really anxious to know what is happening in the literature for patients rheumatology patients and also understanding the use of our medicines in this condition. So thank you for a great review. We've been going through, there's a lot of questions coming through right now, so we're going to go through those, but getting to some of the ones that were asked earlier in the talk. One question or a couple questions about Plaquenil or hydroxychloroquine. You know, you presented a lot of data about viral clearance, but then some of the data on its use in humans to treat the disease. There's some people wondering your thoughts on viral clearance with hydroxychloroquine and whether or not that might have significance about transmission of the virus. If it shows that it reduces viral clearance, do you think that could have a role in reducing viral transmission?
Maybe. I mean, we can't really say that. There's two problems to that. First, I mean, if your study is trying to evaluate viral transmission, you're talking about giving this to an extraordinarily high number of people. To really demonstrate that, I can't even imagine how big the N would have to be, a couple thousand. And when you do that, you're amplifying the cost. I think that the costs of hydroxychloroquine are quite low. I mean, it's a pretty well-tolerated therapy. Combining it with azithromycin, maybe not so much. Well, I think that's an open question. But you know, really demonstrating that would be hard. I don't think that giving someone hydroxychloroquine would to try and reduce transmission would necessarily be wise. I think that for one, we're not entirely sure if those data are true that it reduces viral replication. I think the studies that showed that were all somewhat flawed, and the largest, best RCT that looked at that question showed no real benefit to reduce viral loads. So I think on the one hand, that's an open question, and it's probably, at least right now, I think the data suggests that it doesn't strongly inhibit viral replication. And the second is to actually demonstrate that it would require an enormous randomized controlled trial, and you'd be giving it to a lot of people, and the chances of badness overcoming any benefit are reasonable in my guess. What do you think, Anisha?
I mean, you know, I understand I still think if we were able to show that it does, I think that's still an important concept, because obviously we have different types of outcomes. You know, there's death as an outcome, there's intubation, but viral clearance is still an important one, especially in terms of who knows what's going to happen with the second wave or whatever else. And so I think it's still a reasonable thing to look at and measure. You're right, the most recent stuff didn't really point at that, but I still don't think I still think it's a reasonable endpoint, even though, yeah, I agree you would need a large number to look at. Yeah, so I think theoretically, again, I'm on the theory side of things, so I think theoretically there is some value for it. In practice, I think this is all pretty difficult, so I still think it's worth looking into, and I think a lot of people are, so.
Great, thank you. The next question that we have is, there's a lot of centers for severe patients, it sounds like, that are trying IVIG and Plex. Is there any data for this or anything that you know about?
You know, I haven't seen it. I think there's a lot of interest in convalescent plasma, you know, where you actually take plasma from people who have had COVID-19 and theoretically would have antibodies against it. And I think that's a very interesting avenue of research. There was a paper published of, I think, 5 patients in JAMA, or maybe in the who'd received it. And they'd done well from a sick cohort, but there's no controlled data to indicate that that's a good idea. And the cost of that sort of thing would be astronomical. So as far as IVIG, so if you're just getting normal IVIG from a normal population, it's very unlikely that you're going to be giving COVID-specific antibodies. So I think the idea of that would be more directed towards the immune response itself, and we know that IVIG can be effective. It can be helpful in calming down that sort of response. So I can see why centers are doing that, but there's no strong data that I've seen to recommend it. And Anisha, what are your thoughts?
Yeah, I mean, I think, you know, we all have some confusion about exactly why IVIG works in our patients, and we do use it when people are, I mean, to be honest, and we use it when people are very sick and very inflamed, and, you know, usually when they have some sort of other infection going on. Again, I think I understand the reasoning behind using it. I think that there may be value, and of course, you know, we're doctors and we want to do something, right? But also we want to do no harm. So I think it's always a tough balance to figure out, you know, how active we should be in throwing interventions at people, and then trying to take the step back to figure out what the data is. I don't think there isn't a lot of data. There's a lot of anecdotal, stories of this person did better after getting it. I think like everyone feels, I think it's hard to say, but I do think IVIG, we've used it in a lot of conditions where, like I said, where we're not exactly sure why it's calming down inflammation, but it does. And so in that sense, I think it could play a role. I'm more interested to see how the convalescent plasma goes. I think that's a really great potential target. And as people start developing antibodies, I think that could be super helpful. Yeah, that's kind of what I think.
Great, thank you very much. So next question, trying to collate a lot of questions. There's a lot of questions about the hyperinflammatory state and treatments for that. And you've obviously done a wonderful job of reviewing some of the literature on IL-6 inhibition, and you mentioned IL-1 inhibition. But with what's out there about the hyperinflammatory state, is this macrophage activation syndrome? Is this cytokine release syndrome? What's the difference? All of that in mind, that people are kind of putting out a lot of questions about this. Do you all have any thoughts about why IL-6 inhibition was chosen over IL-1 inhibition for a lot of these preliminary studies? You may have some thoughts about that, you may not. But then the other question that follows out of that is, what are some appropriate patient populations, if not for treatment, maybe for study, that you would consider a good patient population to study for treating that hyperinflammatory state?
Yeah. So as far as why IL-6 over IL-1, I don't have an a priori reason to say that IL-6 would be substantially better. I mean, I think they're both helpful in hyperinflammatory states. IL-6 obviously has an FDA indication for CAR T cell associated hyperinflammatory states. IL-1 inhibition you use for, has an FDA indication for adult onset Still's disease. I think we're all accustomed to trying to use it in things like macrophage activation syndrome. So I think either one is equally plausible. I'm sure there may be some reason to favor one over the other. I have some offline thoughts about why we went with IL-6 instead. But as far as the question of what's an appropriate patient population, I mean, I think that if you're doing this once someone has already gone into a hyperinflammatory state, you might have missed the boat. And so I think a lot of the trials that are addressing this question are doing it earlier. And so the data that I shared was in hospitalized patients who are severe or critical. And I think that's probably the right population. I mean, I don't think we should be giving this to outpatients. That'd be kind of crazy. But if you're sick enough to be in the hospital and you're having respiratory symptoms and impending respiratory failure, I think that's the appropriate group for this to be done in a trial format. As far as like off trial, off label, that's a different question entirely. Anisha, do you have anything on that? Or
I'll let us go to the next question. I mean, I kind of agree with what you're saying. Again, I think IL-6 versus IL-1, it just depends on what part you zoom in on in the whole cytokine storm picture. And so you can easily put a target around either of those cytokines or any others in terms of driving this process. We know IL-6 is a powerful driver of inflammation and cytokine storm. And so I think I agree, hospitalized patients, but with all our diseases, treating early is usually better than treating later. So I do think that some of this might be a little bit missing the boat, and we're throwing it after the person's already sort of had that storm process affecting their lungs, and we're kind of we're catching it a little late. So in terms of when to intervene, yeah, I agree. Not outpatients. I don't think you need to send anyone that gets tested positive on an IL-6 inhibitor or anything like that. But I do think that maybe before they're intubated and in shock and completely sort of in the storm, I think that is probably a better place to try and intervene if we're going to be designing trials around it. But yeah, go ahead. Next question. You guys can go to the next question because I think we're just about one more minute. So
I think we're going to try to sneak in 2 more questions. But outpatient, the ACR guidelines say that anyone who has essentially test positive for COVID should stop all of their biologics or all of their medications except for hydroxychloroquine. It sounds like just regardless of severity. So the question has been, when should you restart, or when do you tell your patients to restart?
So I'll take this one. I didn't know that's. I haven't been telling patients necessarily to stop all of their therapies. First of all, half of the therapies we use are IV and lasting in your system a lot longer than just being able to stop it. For some of the drug, like Plaquenil, whatever, we can keep them on it. But some of the medications, I haven't actually been stopping them immediately. I haven't had a ton of people with my, in my group of patients get the disease, but in terms of restarting, I mean, we're making up this whole 14-day thing. You know, the deadline for when we're supposed to be able to go back to work, when we're supposed to be able to go back into society at all, it's a shifting target. And I think there's really no information. You know, when I have sick patients with bacterial infections, I tell them when they're done with antibiotics, go ahead and start the drug. But the half-life of our drugs, we have to think about that. I mean, we're treating ourselves a little bit more than we're treating our patients when we tell people, you know, stop the drug, because it's really still in their system. That's a personal opinion. That's not, I don't know, Mike.
Yeah, and I mean, I think that the guidelines were a helpful document just because I think that a lot of us are having these questions and having a hard time fielding them. I want to emphasize that, you know, for most of our patients, the guidelines do recommend continuing therapy. So I think trying to taper patients off and risking flares is not the right take home from them. They encourage you to, for most of the time, to continue them. And even post-exposure, I mean, they recommend continuing hydroxychloroquine, sulfasalazine, NSAIDs. They do consider stopping more biologics, but I mean, it's not a strong recommendation necessarily. And then they did recommend holding those sorts of things for patients who are actively infected, but I totally agree. I mean, a lot of these are going to stick around in your system. If you actively have COVID-19 and your patient's pretty sick, it makes sense to hold it, but yeah, it's always a tough decision. And I wouldn't encourage people to be stopping things universally, and I'd absolutely continue steroids and consider stress dose for people who need it.
All right.
One more real quick, and then wrap this up. Yeah.
Yeah, I'm being told that we're out of time. So we had one more question that I think there's ACR guidance on about, you know, what to tell lupus patients who can't find their medicine, or you know, what to do what about lupus patients that are worried about toxicity of the Plaquenil now that there's all these news reports out there. So I don't know if anybody has a 10-second answer to that before we finish. Otherwise, we can wrap up.
I mean, the Lupus Foundation has a list of resources where, you know, we're trying to keep updated with pharmacies. I encourage small, like, forming groups within your region so you can update people and keep lists of pharmacies that do have access to the medication. That's really for the plaque, you know, for access wise. And there's a lot of guidance, and a lot of this is going to be reassuring your patients, telling them that, you know, they've done well on this drug and to continue it. And just as a side note, we'll look through the questions that have come in and you know, get them after the fact and see what we can respond to. I know there's a lot out there,
Yeah,
and I don't have the answers, but we can try.
Well, thank you. This was
yeah. I was gonna say, it's important to emphasize we have 20 years of data that hydroxychloroquine is a safe and effective and important medicine in lupus. And so whatever has been found in the last month, I think is not something that should weigh strongly against that. All right, thanks everybody.
Yep, thank you both. This is a wonderful talk and generated a lot of interest. So thank you both.
Thank you. Stay safe, everyone.